talk to us about sleep apnea. I will pass around the roll, make sure you get it signed so you can get credit for this. Let's turn the tab over to you.
Thank you. I feel all teched out. Got my pointer and my microphone and everything. So I'm Lisa. I'm one of the physician assistants with Dr. Scott Major. That's why his name's up there also. We are part of Wasatch ENT and Allergy, so we do ear, nose, and throat and allergy problems. The reason all those locations are listed up there is we have an office. We work out of here in Brigham. We're on Tuesdays in the specialty clinic inside the hospital. Our main office is in South Ogden. We also have an office in Far West where our other PA works, and we've got an office out in Rock Run, so we kind of make the rounds. Let's see. Oh, we're still working on the clicker. So they asked me to talk to you guys about sleep apnea. So first of all, kind of wanted to go through just a little bit of sleep information. We all go through a sleep cycle every night, and we go through this cycle about 3 or 4 times a night, where we start kind of in level 1, where it's kind of that not quite asleep yet, in between sleep and wakefulness. Your body starts to relax, your heart rate slows down, your brain hopefully slows down. Sometimes it doesn't, in which case it takes a little bit longer to get to that next phase. Finally get to stage 3, that's a place where your body can start making some repairs, which is nice. That's why we like to get to sleep, so we can get some rest and relax. In stage 4, your body temperature starts to decrease as you relax even farther. And then when we get to stage 5, that's REM sleep. You've probably heard of that. REM sleep is also known as rapid eye movement sleep, and that's kind of the goal of where we want to be. And like I said, we go through this cycle in an average night about 3 to 4 times. So when we talk about sleep cycles, we know more about these by doing studies called EEGs, which is an electroencephalogram, where they put the little electrodes all over your head and measure your brain waves. And in the different stages of sleep, we actually see different types of brain waves. So when you're relaxed and waking, we see the ones here at the top, lots of squiggly, almost like you're thinking lots of thoughts. Light sleep, they tend to slow down a lot. Stage 2, they get even bigger. Deep sleep, we get these really big ones. But then, if you look when we get to REM, into dreaming, it's almost like we're thinking again. So these are our sleep cycles here. Again, REM sleep is kind of the goal of where we want to be. Our body needs that to be able to really rest and recover and function properly, and actually to be able to learn and to be able to retain information. We need to get REM sleep. So during REM sleep, our muscles are paralyzed. That's when we have dreams, like I said. And it's the most restful kind of sleep. So I'm sure everybody's experienced those nights where you kind of go through sleep and wakefulness, you don't get a really good deep sleep, and you don't feel rested in the morning. That's because you missed out on that REM sleep quite a bit that night. So everybody has what's called a circadian rhythm, and this is kind of what tells our body when to sleep and when to be awake. And so according to the CDC, they say that it's a physical, mental, and behavioral changes that follow roughly 24-hour cycle. I actually read it was 24 hours and 11 minutes, which I thought was interesting. Oh, wait, go back to that. Sorry. Thanks. Responding primarily to light and darkness. So that's kind of key, especially those of us who don't work on a normal, say, 8 to 5 schedule. If you're working swing shift, if you're working night shift, that really throws off that circadian rhythm because your brain releases melatonin, which is a chemical that helps you go to sleep, and it does that when it gets dark. So I'm sure, if you've worked any kind of off-type shift work, you understand the difficulty in trying to get good sleep during that time. So when we talk about sleep, we talk about sleep hygiene. This is kind of basically the homework, the stuff that you can do or not do at home that can help you get better sleep. So, having a good sleep routine is important. Going to bed at the same time, getting up at the same time. Again, if you're a shift work person, that makes it really hard. But even on the weekends, even on your days off, kind of following that similar type of pattern helps you get better sleep. Minimizing caffeine, nicotine, and alcohol late in the day. Those will all affect the brain chemicals, and they all affect your sleep cycles as well. Taking daytime naps, which I know if you don't get good sleep at night, first thing you want to do is take a nap when you get a chance, but then that also disrupts your sleep cycle as well. So trying to avoid that so that you get good quality sleep at night is helpful. Avoid eating 2 hours prior to bedtime. We see a lot of this in the office is people who have acid reflux. A lot of times you don't realize it, but you have symptoms that are different than heartburn symptoms. But that can help keep you awake at night if you eat within 2 hours of lying down. Avoiding exercise about 4 hours prior to bedtime. Exercise is fantastic, it releases good chemicals in our body, but sometimes they're wakeful chemicals. So if you can, try to do that in the morning or earlier before bedtime. The TV in the bedroom is you kind of train your brain, if you're watching TV in bed, that your brain says, oh, well, when I'm in bed, I get to watch TV, so I don't need to go to sleep. But if you avoid the TV in the bedroom and basically use the bedroom for sleeping and sex, then your brain knows that's what's going on there. And then the last one, there's actually been a lot of research done on this computer screens and phone screens, and how many of us lay in bed and look at our phone or, scroll through Facebook or social media or check our email or whatever right before we go to bed. So the computer and phone screens are what we call a blue light. And so like I said, there's a lot of studies being done, especially right now, showing that blue light stimulates the brain and it changes our cortisol levels. And cortisol is one of the things that we need for sleeping, and the computer and phone screens will change that. So trying to avoid that can be helpful also. Oops. All right, there we go. Sleep apnea, definition is periods of not breathing or breathing that causes insufficient oxygenation of your blood. So you might be breathing, but it might be too shallow, or it might not be getting good oxygen into your blood. So we have 3 different kinds of sleep apnea. We have central sleep apnea, obstructive sleep apnea, and then mixed, which is a combination of the 2 of those. So when we talk about apnea, there can be lots and lots of different symptoms, and you don't have to have all of them, and some people only will have one of them. So snoring is one of the big ones. Now you can have sleep apnea, meaning you have those decreased oxygen levels, and not snore. You can also be a crazy loud snorer and not have sleep apnea because you're still getting good oxygen levels. But oftentimes there is that overlap. Sometimes, people will come in and say, my husband, my wife, they've seen me stop breathing when I sleep. I'll stop breathing for a minute, then I'll kind of jerk awake, or I'll snort myself awake and start breathing again. A lot of people will complain about waking up tired in the morning. Also, that's hard because I think, well, we're adults, we get up, we go to work, we do everything. Is there a time when we're not tired? I don't know. Daytime drowsiness, so like falling asleep when you're driving, or feeling like you're going to fall asleep when you're driving, or as soon as you sit down to watch TV, you fall asleep, those kind of things. Being irritable, being forgetful. I know some of you are probably going through a checklist about your spouse right now. Yep. Feeling sleepy while driving, we said that already. And then daily or frequent headaches. That's a really common one that people don't usually think about sleep as being the first one. But if you wake up with a headache most mornings, it may be because you're not getting good oxygen at night. So what we do to diagnose this, we can kind of do 2 different things to look into this. So one of them is an overnight pulse oximetry. And that's a test, it's kind of like a quick and dirty test. It's something that oftentimes is inexpensive or even free. And you basically get a home monitor, the little monitor they stick on your finger when you go to the hospital to check your oxygen level. It's like that, and you wear it all night, and it monitors your oxygen levels and sees how many times it drops down below the ideal levels. So that can kind of give you a first idea, especially if you're not really sure. And if that comes back, says, yeah, you're having a lot of episodes where your oxygen level's dropping down, then we'll oftentimes go to the polysomnography or the PSG, or the sleep study. I think this is possessed. Okay. So when you get that sleep study, they send us back pages and pages of, remember those squiggles that we saw of all the sleep, cycles? Pages and pages, but what we look at is a specific number called the AHI or the RDI, and that means the apnea-hypopnea index, or now I can't think of RDI, what it stands for, something else index. They're essentially the same number. But what it means is how many episodes per hour that your oxygen level drops below, that ideal level. And when we look at that number, we put it in one of those three categories. So if you're 5 to 15 for your number, you're mild sleep apnea. If you're under 5, you don't have sleep apnea at all. Moderate is 15 to 30, and severe is 30 plus. Now 30 plus can be anything. It can be 31, and I've seen them as high as 75 or 90. So that means 90 times an hour, your oxygen level is dropping below ideal. It is. It's definitely possessed. So, let's see, can I switch this? All right. So some people are more at risk for sleep apnea than others. Obesity is the #1 risk factor. The more weight you're carrying, the more pressure you have on your chest, the more weight you have on your neck, that's going to help to close your airway. A large neck circumference, so like men when you're buying your shirts, if you're over a size 17 inches, you're at a higher risk also. High blood pressure, being a man, family history of sleep study, smoking and alcohol use. Now, these are the things that we know put you at risk for sleep apnea, but you can have none of these and still have sleep apnea. You know, you can be 6 feet and 170 pounds and still have sleep apnea. It still happens. And some of those things, obviously, we can do something about, and some of them, obviously, we can't do anything about. Can't do anything about the fact that you're a man, can't do anything about the fact that you have a family history of sleep apnea, but you can quit smoking, you can decrease your alcohol use, you can exercise, and all of those fun things. So central sleep apnea, sorry that's kind of small, I'm not sure why. Central sleep apnea means that the problem is in your brain. Your brain is not telling your body that it needs to breathe while you're sleeping. There can be lots of different causes for this. Heart failure is one of the causes for this. Hypothyroidism, if it's not controlled by medication, can be one of these. And then any kind of neurological condition like Parkinson's or Lou Gehrig's disease, Alzheimer's, all of those things that affect the brain can affect the brain telling your body to breathe. The treatment for this is to treat the underlying cause as best we can. I mean, in a lot of those things you can't treat very well, but we do the best we can with those. Much more common is the obstructive sleep apnea. And so that's obstruction of your upper airway. And we divide the airway into 3 different levels. Your nasal airway, your oral airway, and then your pharyngeal airway, which is kind of like the throat area. And the blockages will cause decreased or paused breathing that lasts up to 20 to 40 seconds. Now, if you're the person who has an AHI of 90, your episodes probably aren't lasting that long, but you're having a lot more of them. So when we talk about nasal obstruction, we have a few different things to look at. So first thing is a deviated septum. So if you look up in this top diagram, you see this blue line here. That's your septum. It's your middle divider between the left side and the right side of your nose. And it should be in the middle. If you look down here at this bottom diagram, you can see it's shifted over here to this person's right, to our left, making this left passage much larger and this right passage much smaller. So the air that's trying to flow through that right side is obstructed, hence the obstruction of your breathing. The other thing we can get inside the nose is called hypertrophic turbinates. Hypertrophic means it's bigger than it's supposed to be. So this is a CAT scan. This is one of the things that we'll look at if you're having nasal problems or sinus problems. So again, here's our picture. So here's our septum, nice and straight here. And then these little comma-shaped things here, these are turbinates. They help to circulate the air inside your nose, and they're supposed to be there. But they're supposed to look like this. But if you look over here, almost your entire nasal space is taken up by these big, huge turbinates. And we see that a lot in people who have allergies or chronic sinus issues. They can just get really big and oversized. But that can obstruct your airflow in your nose as well. Okay, so so far as oral obstruction, there's a few different things in your mouth that can cause problems. So one of them is tonsils. Now in adults we don't see tonsils as commonly as a problem, but we definitely see it as a problem. We grade tonsils on a scale of 1 to 4. 1 being they're very small and kind of just tucked in the side here. 2 is a little bit bigger. This is probably a 3, and a 4 would be at the center. So if you look, normally this whole area should be for airspace. But if you look at it, probably 50 to 60% of it is taken up by those monster-sized tonsils. So that can definitely cause a problem. Okay, other things in the throat that can cause obstruction. This is the uvula, the little thing that hangs down the back of the throat. If that gets really big and oversized, that can cause obstruction. Sometimes I've seen them long enough that they actually hang down and sit on the tongue. They get pretty big. The tongue, and then the tonsils as well. So up here, this is the soft palate, and sometimes people have a really long, soft palate that goes down towards the tongue, and that also closes off space. So there's a scoring mechanism that we use to kind of grade people, and you can do this at home. You can take a look in the mirror and see where you fall. So this was actually developed by anesthesiologists to see how easy somebody would be to intubate. But if you look in your mouth, in the mirror, and you see, like you can see your whole uvula and all this space, you're a class 1. So this means obviously you have the most space. A little bit less, you can't see the tip of it. You can only see a little bit of it, class 3. And then class 4, you can't see it at all. So if you can imagine that class 4 person is already obstructed just because of the way they're built. So this is we talk about the pharyngeal obstruction, kind of in the back of the throat area. That's where your tongue kind of plays a role here. So if you look here, so this blue is like the air flowing through the nose nicely. The tongue is sitting up here. And here, the tongue, he's laying on his back, and the tongue is fallen back, and it's pinching our little blue arrow of air. So this is obstructed back down here. So we can do a few different things when we talk about sleep apnea. The CPAP is the first one. Different devices are the second one, and then surgical options is the third thing that we can do. So you've probably all seen a CPAP machine, or not heard of somebody, or you know somebody that's got one and probably loves it. CPAP is the gold standard for treatment for sleep apnea. And what it does, if you don't have one or haven't used one, it's a mask that looks like this. And there's different types depending on what kind of a sleeper you are. If you're a nasal breather, you can get just a nasal mask. You can get one that goes over your whole face. But what it does is it pushes pressure into your airway, through your nose, through your mouth, wherever your breathing occurs. And kind of by virtue of having a lot of pressure go in, it opens up that airway space. It kind of forces the air in. It's not oxygen, so you don't have to have any more oxygen. The oxygen that's in the air is plenty. It's just not getting to where it needs to be. So the CPAP machine will do that for you. And there's a couple different kinds. The CPAP is usually the first type of machine we use, it means continuous positive airway pressure, which means it's just one strength of pressure pushing in there. A BiPAP machine has two pressures, an inhalation pressure and an exhalation pressure. And then there's the VPAP, and that's a variable one. Usually you don't get to the VPAP until you've tried the other ones and they haven't worked. CPAP machines, they're kind of like a love-hate relationship. I have a lot of people who start on a CPAP machine and give up really easily because they feel like they're failing. And like, I tried it and I couldn't sleep at all for 3 nights. I haven't slept in 3 nights, I can't do this, I'm done with it. So usually what we'll tell people is, take it slow. Just like anything, it takes practice. Try wearing it an hour at night. And if you can keep it on for an hour, great. Even if you don't have it on for the rest of the night, that's fine. Take it slow. Even if you're getting, I have a lot of people say, well, I'm able to use it, but, at 4 o'clock I get up and go to the bathroom and then I can't put it back on and go back to sleep. But at least you're getting 6 hours of sleep with it on with good oxygen levels, so it's doing some good. I also have other patients who have learned to love it and they wear it and they can't sleep without it because they feel so much better with it. But I think the key with the CPAP is really to take your time with it. And again, nobody loves the CPAP machine, especially when you first get it. It's not cute or cuddly or sexy or any of those fun things. It can be loud, they can be obnoxious, but sometimes it's just a matter of, you try out a few different masks, you see what works better for you, and again, you give it some time. So that's the gold standard of treatment because it works the very best. And once you've been on a CPAP machine, then they do studies, the company that usually provides you your machine, they'll do studies and send us back data that says, hey, remember those numbers, the 5 to 15, the 15 to 30, those numbers? And they'll be like 2, 3. So we know that you're getting good oxygen all night long. So the other thing we can do are devices, like things you can put in your mouth. We call them oromandibular devices or like mouth guards. That's kind of the idea. And this is just a picture of one of them. But the idea here is that you put this mouthpiece in your mouth. And remember the picture? We can go back. Here we go, this picture. So the tongue is fallen backwards here because the whole jaw has relaxed and is falling back that way. But the idea is if you can put a bite guard in your mouth, it will help keep your jaw pulled forward and keep that tongue off of the back of your throat. Now that can be helpful for some people. Some people don't tolerate it really well, just like any of these things. They can be kind of expensive. The other kind of negative thing is they can stress out your TMJ joint, your temporomandibular joint here, cause some TMJ issues. But some people are like, you know what, I tried the CPAP machine and I can't do it. It doesn't work for me. I've got to try something else, and this can be a good option for you. This is something to be made by like either a dentist or like an oral surgeon. So then the third option we have are like surgical options, and that's kind of, you know, that's more what I do with these things. So we talked about the turbinates. Remember those little comma-shaped things inside the nose? So I showed you the picture where they were big and huge. And if you're somebody who has allergies, who has big turbinates, then we can go in and we can correct that. And that's done surgically. It's an outpatient surgery. And basically what we do, these little things kind of run the entire length of the nose. We basically trim them back. So we kind of take it from looking like this, more to looking like this. Again, we still have them, we still need them, but they don't have to take up all of your airway. Usually this is about a 3 to 4 day recovery to have something like this done. Let's see. The other one is, or the next one I should say, is a deviated septum repair. I'm pushing this arrow here. I'm not really sure. I think it's really sensitive. Alright. I'm going to go there and I'm going to put that down so I don't mess it up again. Okay, so a septal reconstruction, that is, you know, where your septum is deviated. We saw the picture of where that blue line was pushed over to the side. Usually people get deviated septums from some type of a trauma. A lot of times you don't remember what it was. It could be, you know, you got knocked out in a fight. You'd remember that. It could also be you ran into a wall when you were 2 years old and you don't remember that. But some kind of a trauma pushed that cartilage over to one side or the other. And usually over time, especially as you become an adult and get older, that can get worse and worse and worse, or you become more and more aware of it. So that's also a surgical fix because it's a structural problem. That surgery is all done in through the nose. If you talk to anybody who had that done about 15 years ago, it was like probably the worst experience of their life because they went home with literally 6 feet of gauze packing. You're nodding, you know somebody.
My husband.
Yeah. Who had 6 feet of packing up their nose, and then they take the packing out and they pull it and they pull it in the office. So the good news is we don't do that anymore because people hated that. So what we do instead is we go in and correct the septum, center it, and then we put a thin plastic splint kind of sandwiching the septum on the inside. So you can't see it from the outside. And that stays in for about a week. We do take that out in the office, but it's much less unpleasant than having the gauze packing removed. Mostly with the turbinates and the septum, you have a lot of congestion, but it's not a super painful procedure. It's not like you're on pain medicine for a week. I mean, when we do the septum, we usually also do the turbinates because we're there and we're trying to open up the airway and maximize things, so we do both of those things. And both of them are about a 3 to 5 day recovery, you know, when we talk about that. So it's not too bad. The only thing we don't want you doing is heavy lifting for about 10 days. Tonsillectomy and adenoidectomy. Now, the adenoids, I didn't have a picture of here for you. Sorry, I apologize for that. The adenoids are like tonsils, but they're in the back of the nose instead of the back of the throat. So they're in the airway. But the good news is, if you're over about 25 or 30, your adenoids are gone. They atrophy and they disappear by the time you're about 25 or 30. So adenoids aren't an issue. We see adenoids being an issue in little kids. Like I have a lot of moms bring in their 2 and 3-year-olds and they're like, he snores like a freight train. You know, most 2 and 3-year-olds don't do that. But if they have enlarged adenoids, that obstructs their airway. And so we'll take out tonsils and adenoids to open up the airway. In adults, again, we don't really have adenoids if you're over 30, but you saw that picture. I've seen plenty of adults with really big tonsils. And they sleep a whole lot better once we get those out of there and open up that airway. That really long word, uvulopalato-pharyngoplasty. We usually call it a UP3 because I can't remember how to say it. What that is, I should go back to that slide. So that's kind of like the works. And I should tell you, the recovery from having your tonsils out as an adult is a good 10 to 14 days. And that's like being down, out of work, on pain medicine, feeling lousy. The UP3 is like one step beyond that. So UP3, we take out your tonsils here. We take out these like little ridges here. These are called the tonsillar pillars. We take off the uvula and down the other side. So basically we're trying to open up that entire area as best we can. That's a good 2-week recovery. It's not any fun, but it can help. Now sometimes, people want to talk about surgery and say, well, what surgery can I do so I don't have to use my CPAP machine? It all depends on your numbers. When we look at that AHI score, if your numbers are, say, at 20, that puts you in a moderate sleep apnea. We know, based on what surgery it is, about how many points to expect improvement when we do surgery. So like, for example, if you've got a deviated septum and we do a septal reconstruction and a turbinate reduction, we know we'll get about 10 points of improvement out of that. So depending on where you're starting, that can really get you to a good place. Now, some people have such a high score and they have so much obstruction that, let's say your score is like a 45. So you're severe sleep apnea, right? No matter what surgery we do, we're not getting you down to 0. But it may be that you have so much obstruction that when you try to use your CPAP machine, the pressure has to go up so high that it feels like you're in a wind tunnel. And that obviously makes it hard to use. So doing something like this, or opening or decreasing the obstructions, can at least help you to be able to tolerate your CPAP machine better and have it be more effective and help you to be able to use it longer. The pillar implants, that's kind of an interesting system. I should have got a picture of that. So basically, on your soft palate inside your mouth, we put a series of 6 little rods. They're about 3/4 of an inch long. And we inject these little rods into the soft palate and kind of the back of your throat. And the idea is, if you're somebody who has a really long soft palate or it's really floppy and it's kind of sinking down or sagging down and blocking your airway, putting these rigid devices in can help it be more like a canopy as opposed to more like a sheet. And when we do that, that can help open up your airway. It's a much less invasive surgery or procedure, I should say, because this is actually something that's done in the office under, wait, I might be lying to you. I can't remember now if this is in the office or not. I think it's in the OR. But the only drawback to this one, because we don't do this a lot, is that insurance does not cover this. Like, there's no ifs, ands, or buts about it. I feel like maybe there's not enough data or whatever for them to say, yeah, this is a good thing. So people who have this done pay exclusively out of pocket for the pillar implants. The last surgical option we talk about is mandibular surgery, or like your jaw, your lower jaw surgery. And that one I'm not an expert on for sure, because we don't do those. That's done by like a maxillofacial surgeon or an oral surgeon, someone who does bony type surgery in the jaw. But basically it involves cutting the jawbone on the lower jaw and sometimes on the upper jaw, and pulling them and re-screwing them and drilling them into different positions. Again, trying to pull that tongue off of the back of the throat area.
Is that outpatient?
No, it is not outpatient. I'm pretty sure, because I think they have to make sure you're eating. Although it depends on which one you're doing, there may be some outpatient ones. But all the rest of them, even the UP3 is outpatient. The surgery is not a big deal. It's the recovery that's the rough part for sure. So the most important part, at least when we talk about the surgery stuff, not everybody's a candidate for every option. You know, if we look inside your nose and say, hey, your septum looks great, obviously doing surgery on your septum is not going to change anything for you. And none of the surgeries are as effective as the CPAP machine. But it can improve your apnea, and like I said, sometimes they can help you be able to tolerate the CPAP machine even better. People always ask me, you know, is this going to fix my snoring? My wife wants to know if this will fix my snoring. So what I tell them is, you know, if we're opening up your airway, we're decreasing your obstruction. And obstruction is one of the things that will cause snoring. But you don't want to have a surgery just to fix your snoring, because you could come out the other side of the surgery and still snore, because there may be obstruction at different levels that we can't surgically fix. So it's kind of a bonus. If it helps with your snoring, that's a good thing. But we don't do surgery just to fix snoring. Insurance companies like to differentiate. See, there's snoring, which is what they consider a cosmetic problem. It's annoying, mostly for your spouse. Sleep apnea is actually a medical problem. You're not getting oxygen to your brain, you're killing brain cells, you're not able to function, and your daytime activities are affected. So that's a medical condition. That's why they do things like they provide sleep studies and CPAP machines and surgery to help fix those conditions. So, does anybody have any questions for me? Is this kind of the information that you were looking for? Stories, good jokes. We can all get out early. Everybody's like, don't ask any questions, but go home early. Okay. Well, if nobody has any questions, that's fine. If you want to come up and ask me a question afterwards, that's fine also. I did bring some of my cards up if you are having problems, if you know somebody's having problems, if you'd like to talk about it, we're happy to do that for you. Like I said, we do have an office here at the hospital in Brigham, so we're fairly close by. Last chance, any questions? Okay, thank you.